This morning, I am very happy to welcome one of our own chief residents, Melissa Meyer. She is presenting for our grand rounds this morning. She received her bachelor's in science in cellular and molecular biology, as well as a minor in music from the University of Michigan. She went on to receive her medical degree from Washington University in St. Louis before joining us here, where we have been very lucky to have her as one of our residents. She is going to present to us this morning on COVID-19, which is a great topic to hear all about. So thank you for presenting to us.
All right, thank you, Dr. Bizzuto. So as the current pandemic has affected every aspect of our lives, there's a lot of information on COVID-19 and the pregnant patient. I know I've personally found this overwhelming and difficult to keep up with, so today I am hoping to break it down to the essentials and discuss current guidance and literature regarding the pregnant patient presenting to labor and delivery with COVID-19 infection. All right. I have no relevant disclosures. I will be using a few product names throughout this document, but don't have any affiliation to those products. First, in terms of my outline, I'll review some background on the virus and its relation to pregnancy. I'll then focus the remainder of the talk on management guidelines for a pregnant patient presenting in labor with both intrapartum and postpartum considerations. I'll end on a brief discussion of severe disease and vaccination. My hope is that after this talk, everyone can feel more comfortable in taking care of and guiding a pregnant patient through their care on labor and delivery. Throughout this talk, I'm going to be using some audience participation questions, so I'm hoping everybody can sign up for this poll everywhere today. I have on the computer might be a little bit easier, but texting is also fine. So if you are texting, you would text to Melissa Meyer 569 to 37607, and I'll give everybody a few minutes to join that poll. Okay, so I will move on, and the first piece is a poll question. So the question is, what is your comfort level in caring for a pregnant patient with COVID-19? The choices are very comfortable, somewhat uncomfortable, or very uncomfortable. And the answers will automatically pop up. Okay, so it looks like we're somewhere between somewhat comfortable and somewhat uncomfortable. All right, so now we'll start off with some background on COVID-19. In March 2020, the WHO declared COVID-19 a pandemic. The virus, severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2, is an RNA beta coronavirus that is infectious by binding to the host cell ACE2 receptor through its spike protein. The primary mode of transmission is person-to-person respiratory transmission. There is some evidence that SARS-CoV-2 can also be transmitted through the airborne route. However, this is not the primary mode. And as we are all aware, the risks are higher with close contact. UW and Unity Point Health Meritor guidelines state that a close contact is defined as any individual who was within 6 feet of an infected person for at least 15 minutes, starting 2 days before illness onset, or for asymptomatic patients, 2 days prior to a positive test result until the time the patient is isolated. The incubation period, or the time from exposure to development of symptoms, is between 2 and 14 days. There is the potential to transmit coronavirus prior to the development of symptoms, with transmission most likely to occur in the early stages of infection. Transmission can occur in both asymptomatic and symptomatic individuals. Symptoms of COVID-19 can be extremely variable and include all of those listed on this slide, with about 40 to 45% of individuals being asymptomatic. Lab abnormalities can include lymphopenia, thrombocytopenia, elevated liver enzymes, LDH, CRP, and D-dimer, and acute kidney injury. Findings on chest imaging can be nonspecific, but these can include patchy infiltrates on chest CT, or chest X-ray, and ground glass opacities on CT scan. Abnormalities tend to be bilateral with a peripheral distribution and involve the lower lobes. Testing options can include nucleic acid amplification testing with reverse transcriptase PCR and antigen testing. The gold standard remains the nucleic acid PCR testing. Specimens can be obtained as a nasopharyngeal swab, nasal swab, nasal or nasopharyngeal aspirate, oral pharyngeal swab, or saliva specimen. Studies have found that nasopharyngeal and saliva specimens have similar sensitivities. This study from the New England Journal in September 2020 shows the correlation of nasopharyngeal and saliva samples in the graph shown here. Another study in the Journal of Clinical Microbiology in November 2020 evaluated over 1,100 specimens and found excellent agreement between provider-collected nasopharyngeal swabs and patient self-collected saliva. Regarding the antigen testing, while it can be rapid, they have lower sensitivity, and in a symptomatic patient, a negative test result should be confirmed with a nucleic acid PCR test. Patients can have persistent or recurrent positive PCR testing. Regarding testing at Meritor, the algorithm is broken down here into within 30 days of a positive test, in which case aerosol generating procedures need to be done in a negative pressure OR with full airborne PPE precautions, to within 31 to 90 days, where if a symptomatic patient is present, then negative pressure room and airborne precautions should be employed during an aerosol generating procedure, and within 90 days, where a patient needs to be retested. Of note, if a patient requires more than 6 liters per minute of oxygen by nasal cannula, this is considered aerosolizing. A recent update from Meritor in December for surgery and procedures divides patients into 20 days and 90 days, with symptomatic patients being retested. We'll now move on to pregnancy and coronavirus and start with another poll. So this is a word cloud. I'd like everybody to write down one word, and then the more people that say the same words, the bigger they will get. Try not to do a phrase because it breaks up the words into individual words. So the question is, what word comes to mind when thinking about pregnancy and COVID-19? So it seems like unknown and scary, uncertainty, stress, risky are big things that people are thinking about. Makes absolute sense. All right. As we all know, there have been many pregnant women infected with coronavirus. As of December 7th, the CDC reported that a total of 44,183 pregnant women were confirmed positive for COVID-19 in the United States. When thinking about the effects of COVID-19 in pregnancy, it is important to consider the normal maternal physiologic changes that predispose a pregnant woman to poor outcomes and respiratory illnesses. These include the impact of the gravid uterus on lung volumes, leading to basal atelectasis and reduced functional residual capacity. Additional physiologic changes in pregnancy include increased oxygen consumption, increased heart rate, thromboembolic disease, and altered cell-mediated immunity. All right, I just need to get back to my screen one moment. Okay. Historically, pregnant women have been known to be at increased risk of adverse outcomes from respiratory illnesses. In regards to influenza, healthy pregnant women have been found to have a 4 to 5 times increased rate of serious illness and hospitalization. Complications occurring from influenza include preterm delivery, pneumonia, hospital ICU admission, and maternal or fetal death. Higher rates of hospitalization and mortality were seen during the 1918 influenza pandemic, as well as the more recent 2009 H1N1 pandemic. Looking back at the previous coronavirus epidemic, SARS-CoV and MERS-CoV, significant adverse effects were noted in pregnant women. In the 2002 to 2003 SARS epidemic, about 100 cases of SARS were identified in pregnant women. Adverse outcomes included severe maternal illness, maternal death, and spontaneous abortion. Very few pregnant cases were documented in the MERS-CoV epidemic in 2012. In the general population, MERS was found to have a higher case fatality rate than SARS, with about a 34.4% rate in the general population. Pregnant women were found to be a high-risk group with increased risk of developing severe disease with associated maternal and fetal outcomes. In both of these previous coronavirus epidemics, vertical transmission was not identified. Looking at what is known about the SARS-CoV-2 virus in pregnancy, a CDC mortality weekly report was published on November 6, 2020. This report evaluated increased risks of symptomatic pregnant women with COVID-19 infection compared to their symptomatic non-pregnant counterparts. 461,000 women positive for COVID-19 were identified, with 409,000 symptomatic. Of those, 5.7%, or 23,000 women, were pregnant. Overall, the report found that while the absolute risks of severe outcomes were low, pregnant women were at increased risk for severe illness. The symptoms most commonly identified in the study were cough, headache, muscle aches, and fever. Overall, symptoms were reported less frequently in the pregnant population. This report found that pregnant women were more likely to be admitted to the ICU, receive invasive ventilation and ECMO, or die compared to non-pregnant women. This study highlights the importance of vigilant care of the pregnant patient with COVID-19. Regarding the risk of vertical transmission, while it is theoretically possible, we have not seen many reports. Throughout this pandemic, I have been wondering what would be considered a vertical transmission. In a presentation from an SMFM webinar in April 2020, Dr. Gaw provided this table created from a paper by Shaw et al. That explained what could characterize a vertical transmission. Looking on the left side of this table, this could include a positive cord blood sample, neonatal blood at less than 12 hours, or positive amniotic fluid prior to rupture of membranes. Since then, multiple studies have shown that while the risk of vertical transmission could be possible, it is unlikely and quite uncommon. Evidence includes this systematic review in AJOG, published in July 2020, reviewing 936 newborns, which found low rates of vertical transmission without significant consequence to the newborn. When caring for a pregnant patient with COVID-19, it is important to think about the severity of the illness. 5 classifications have been described to help assess level of severity of a COVID patient. These classifications were described by the NIH and SMFM. An asymptomatic infection describes the patient with no symptoms. Mild disease refers to a patient with flu-like symptoms without dyspnea, shortness of breath, or abnormal chest imaging. Moderate disease includes evidence of lower respiratory tract disease while continuing to maintain SpO2 greater than 93% on room air. And severe disease includes respiratory rate greater than 30, hypoxia with oxygen saturation less than or equal to 93%, a P to F ratio of less than 300, greater than 50% lung involvement on imaging, and critical disease with multi-organ failure or dysfunction, shock, or respiratory failure requiring mechanical ventilation or high-flow nasal cannula. In regards to delivery planning, in the asymptomatic and mildly symptomatic patient, timing of delivery should be per routine obstetrical indications. For patients who test positive between 37 and 38 weeks, 6 days, SMFM recommends expectant management to be considered until 14 days after a positive PCR test, or 7 days after the onset of symptoms, and 3 days after symptom resolution. After 39 weeks, SMFM states that delivery can be considered to decrease the risk of worsening maternal status. Throughout labor, delivery, and postpartum, COVID-19 positive patients should be wearing a mask. Now we'll move on to labor. We have all interacted with many patients struggling with the impact of COVID-19 on their pregnancies. I want to show this video to highlight some of the feelings of expectant mothers.
I got it right here.
There are times where I'm like, I've got this, I'm strong, I can deliver a baby on my own, and then the next minute I'm crying for hours in the shower. Not only am I 39 weeks pregnant, but I also have a husband who's an ER physician on the front line every day. I worry not only about him every day, being exposed to positive patients, but I also worry about myself.
I am a registered nurse, so instead of taking my leave at 39 weeks, I decided to take it early. I idea how it's going to work with getting paid.
My doctor can tell me all these things right now. In 3 weeks, like, what's it gonna look like then? With my last pregnancy, I hemorrhaged a lot, and I had to have a blood transfusion. And I know the blood banks are starting to run low.
I want to be prepared in case of disaster area there, and that I don't want to be at the hospital. But I'm also getting a lot of information from friends and family being like, don't deliver at home, that's so dangerous. And other people, don't go to the hospital, that's so dangerous. And so it's just so much information to process.
How do we deal with this? Do we switch providers? Do we switch hospitals?
It'll be Raina kind of by herself with me and our doula supporting virtually.
I was there when our daughter was born. I held her first because I had a C-section, and that was like a really important moment. And the idea that she wouldn't be there was heartbreaking. So now, at almost 38 weeks pregnant, I decided to have home birth.
I'm already just assuming that I will be work alone. The biggest reason why you have a support network when it comes to the hospital is so that someone's watching over you often and looking up for you and communicating what your needs are. Now I'm going to have to do that for myself.
There is no signs of, the virus slowing down. So as much as things continue to continue this way, my husband is going to be working more. So there are times where he probably will stay away from us for, a few days or weeks.
But we have in our kitchen a big sliding glass door, and our plan is to have the deck chairs out there and allow people to come and sit in the chairs. And we'll stand on this side of the door with the baby so they can see him.
All right, thanks, Lisa.
Yeah.
I will go back to sharing my screen here. And then, great. All right, so we should be back on this outline slide. So I hope that video, I know it was a little choppy, but was able to highlight some of the things that pregnant patients are thinking about during this time. When the pandemic began, it was unknown how many patients would present with asymptomatic infection, and if there would be any utility in universal testing on labor and delivery. One of the first large studies on this topic was published in April 2020 in New York City. This study evaluated 215 pregnant women and found that more than 1 in 8 asymptomatic women were positive for COVID-19. In fact, most of the positive cases identified were asymptomatic. The 15.4% prevalence rate of infection was 21-fold higher than the reported prevalence in New York City at the time. A follow-up study in Chicago from April 8th to April 27th found a 3.6% positive rate, with 43.5% of those positive patients presenting with asymptomatic infection. The rate was 6-fold higher than the reported prevalence rates in the country at the time. These studies showed that symptom screening could not be used reliably to identify pregnant patients with coronavirus. Subsequent studies have continued to identify high rates of asymptomatic testing. ACOG currently states that symptomatic pregnant women should be prioritized for testing, and that facilities can consider additional testing strategies, such as universal testing, particularly in high prevalence areas. Now for another poll. Meritor adopted universal testing on April 23rd, 2020, and has been tracking the positivity rates weekly. Looking at the data through November 2020, what do you think the positivity rate for labor and delivery patients on Meritor was from November 23rd to November 29th? Okay, looks like we're pretty split between 3%, 5%, and 7%. Okay, so the number is 3.03% for that week. This graph represents the positivity rates at Meritor since April 2020. The weekly rates of positivity have ranged from 0 to 5%. The highest period of infectivity was through November was 11.1 to 11.8 at 5%. As a laboring COVID positive patient moves to labor and delivery, there are a few things to consider. Continuous fetal monitoring should be used, as an increased number of non-reassuring tracings have been reported. As the virus has rarely been detected in vaginal secretions or amniotic fluid, and there is an unlikely risk of maternal to fetal transmission, interventions such as rupture of membranes, placement of internal monitors, and operative delivery can be performed for the standard indications. As a nasal cannula and face mask are in contact with maternal respiratory tract secretions, use of supplemental oxygen increases exposure between the patient and the provider. As intrapartum oxygen has not been proven to have fetal benefit, recommendation is to avoid using supplemental maternal oxygen for fetal status alone. It should only be used for maternal hypoxia. In regards to pain management, there are a few considerations to be aware of when dealing with a COVID positive patient. COVID-19 alone is not a contraindication to neuraxial analgesia. Therefore, an epidural can be offered. In fact, Anesthesia Society guidelines state that early epidural analgesia may decrease the need for general anesthesia in emergent cesarean delivery. When aerosolizing procedures are performed, such as with general anesthesia, airborne PPE precautions should be followed. And if extubation is planned, this should be performed in the operating room so that airborne precautions can be maintained until the patient is ready to be transferred. Nitrous oxide should be avoided in labor because of the risk of aerosolization, as the process involves respiratory contamination. There are a few other considerations to discuss, which become more pertinent to consider if a patient has severe disease. Regarding fluids, it is important to monitor intake and output closely. Patients with COVID-19 are susceptible to fluid overload. Therefore, effort should be made to avoid aggressive hydration and moderate to severe disease, as this could lead to pulmonary edema or worsening maternal oxygenation. This should all be taken into the context of avoiding hypotension and organ hypoperfusion. Per SMFM, close monitoring of fluid intake and output should consider especially for the first 24 to 48 hours postpartum as well. Regarding the use of magnesium sulfate, there hasn't been reported data on the impact of magnesium sulfate on COVID-19 and obstetrics to date. Therefore, it is currently recommended to use per the routine indications. However, given the potential respiratory complications with the use of magnesium and the risk of pulmonary edema and preeclampsia, in patients with severe COVID-19, intake and output should be monitored closely, and consideration of dose adjusting or withholding magnesium should be made on an individualized basis. In other respiratory illnesses, antenatal steroids have been associated with possible worsening of pulmonary status and viral shedding. Therefore, ACOG initially recommended offering antenatal steroids prior to 32 weeks and not late preterm steroids. However, more recent information actually supports the use of steroids in the treatment of ill COVID-19 patients without appearing to have maternal harm. Therefore, ACOG currently recommends offering steroids per routine indications. Going to the second stage, when complete, the patient should start pushing and not labor down. Delayed pushing has been shown to prolong time to delivery, increase chorioamnionitis, and postpartum hemorrhage. It continues to be discussed whether forceful exhalation during the second stage is considered an aerosol generating procedure. Per the CDC and endorsed by ACOG, based on limited data, pushing would not be expected to generate aerosols to the same degree as other procedures that are considered aerosol generating. Therefore, forceful exhalation during the second stage of labor is not considered an aerosol generating procedure for respirator prioritization during shortages over procedures more likely to generate higher concentrations of infectious respiratory aerosols. However, a publication in April 2020 in the American Journal of Perinatology urged labor personnel to consider the second stage an aerosol generating procedure, given the close proximity of healthcare personnel to the patient and possible multi-hour duration of the second stage. A subsequent publication in AJOG in May 2020 has a suggested PPE in the table shown here, recommending healthcare providers don droplet PPE as well as an N95 during the second stage. The recommendation was made for any patient during the second stage, regardless of symptoms. It is unclear how this recommendation should be interpreted in the setting of universal testing. Nonetheless, it's important to consider these points in these studies, particularly for patients with pending COVID tests on labor and delivery. After the baby has been delivered, ACOG continues to recommend delayed cord clamping. A study from Spain evaluated 403 pregnant women from March 1st to May 31st, evaluating neonates that underwent early cord clamping versus delayed cord clamping, and looked for the development of infection of the neonate within 14 days. There were no differences identified in perinatal outcomes and no confirmed cases of vertical transmission. Therefore, routine guidelines for delayed cord clamping should be followed. Given concern for shortage of blood products and preventing anemia, extra care is recommended to avoid postpartum blood loss. One study from AJOG in May 2020 suggested prophylactic TXA and 400 micrograms of buccal meso, in addition to starting oxytocin administration postpartum. Institutions could also consider using cell salvage technology during cesarean. However, regarding tranexamic acid, ACOG states that given the possible additive effect of the hypercoagulable state of pregnancy and increased risk of thrombosis in COVID-19 infection, providers should consider the increased risk of clotting when administering TXA and consider administering this medication when other postpartum hemorrhage medications have failed. It should be noted that studies have not shown an increased risk of postpartum hemorrhage with coronavirus, including this study from Boston published in December. These are the UW and Unity Point Health Meritor guidelines for what we've talked about thus far, including antenatal corticosteroids per routine guidelines, using an N95 in the second stage for COVID positive and PUI patients, with delayed cord clamping being acceptable, and prophylactic hemorrhage prevention with misoprostol. Now we'll move on to some postpartum considerations. ACOG, SMFM, and the CDC state that limited data do not suggest a difference in infection rates, whether the neonate remains in the same room or a separate room from the mother. Therefore, based on the benefits of close contact between the mother and neonate, including successful breastfeeding and bonding, rooming in should continue per the typical hospital policy. Of course, there are exceptions based on worsening maternal or neonatal status that require a higher level of care. The criteria listed on this slide are used for discontinuation of isolation and precautions, including 10 days from when symptoms started, at least 24 hours from the last fever, and symptoms improved. Regarding breastfeeding, this can continue. Breast milk is not a likely source of SARS-CoV-2 transmission. In fact, per the CDC, transmission of SARS-CoV-2 to neonates is believed to primarily be through respiratory droplets postnatally when the neonate is exposed to caregivers with COVID-19. Therefore, it is important that when breastfeeding, mothers practice preventative cares. This includes wearing a mask and appropriate hand hygiene if directly breastfeeding, and properly cleaning a dedicated breast pump if pumping, with consideration of having a healthy caregiver feed the neonate the expressed milk. A systematic review published in October 2020 reiterated these findings. This study evaluated over 650 mothers and neonates and found that neonatal COVID-19 infection is uncommon and uncommonly symptomatic. Additionally, the rate of infection is not increased whether the infant is born vaginally, breastfed, or in contact with the mother. For pain management postpartum, women should continue to be provided acetaminophen and NSAIDs. There was initial concern that because NSAIDs increase ACE2 expression and the SARS-CoV-2 virus binds to cells through the ACE2 receptor, that NSAIDs could result in worsening disease. However, this has not been further substantiated, and SMFM recommends continued use of NSAIDs postpartum unless there are underlying renal concerns. Regarding thromboprophylaxis, in general, pregnancy and postpartum are hypercoagulable states with a 4 to 5-fold increased risk of thromboembolism. Given that SARS-CoV-2 may lead to increased coagulopathy, these factors may be additive. ACOG states that while there is not direct evidence to recommend ordering or not ordering anticoagulation treatments, it is reasonable to consider ordering, particularly in severe or critical illness. The Royal College of Obstetricians and Gynecologists recommends that all pregnant women that have been hospitalized with COVID-19 be offered 10 days of prophylactic anticoagulation after discharge or longer if there is persistent morbidity. Lastly, we should not forget to evaluate for depression and continue with routine depression screening, particularly with the added stress and anxiety that come with the pandemic. A study from Canada published in November 2020 found elevated depression and anxiety in pregnancy during the coronavirus pandemic, with potential protective factors including increased social support and exercise. Another study published in November from Boston showed pregnant women with pre-existing mental health diagnoses being at increased risk of worsening anxiety and depression during the pandemic. These are the UW and Unicorn Health Meritor guidelines for the postpartum considerations that we discussed, including rooming in being okay to continue, breastfeeding encouraged, NSAIDs acceptable, and prophylactic anticoagulation for 10 days after diagnosis for patients with moderate to severe disease. Now that we have discussed the overall management of the asymptomatic or mildly symptomatic COVID-positive labor and delivery patient, I want to briefly discuss characterizations of severe disease and current treatment options. In the SMFM management considerations, there is an algorithm for when a hospitalized pregnant patient should have a consult with an intensivist and when ICU admission is necessary. If any of these considerations are present, including inability to maintain oxygen saturation greater than 95% with supplemental oxygen, hypotension despite appropriate fluid resuscitation, or evidence of new end organ damage, then there should be a consult with an intensivist. If there are persistence of these symptoms, inability to increase frequency of clinical assessments, intubation, or need for other end organ support, then admission to the ICU is warranted. A discussion of treatment of critically ill COVID-positive pregnant patients would be a talk within itself, so I would just like to highlight a few of the treatments that are currently being used in symptomatic COVID patients, including those that are critically ill. In general, mechanical ventilation and prone positioning have been used in pregnant patients. Regarding medications, in the non-pregnant setting, glucocorticoids are thought to have a role in the management of critically ill patients with COVID-19. In a New England Journal of Medicine article, there was a lower 28-day mortality among those receiving invasive mechanical ventilation or oxygen alone. Therefore, dexamethasone has also been used in the pregnant population. The dosing is typically 6 milligrams daily for 10 days or until discharge. And if additionally being used for fetal lung maturity, using dexamethasone 6 milligrams IV every 12 hours for 4 doses, and then continuing the course as above. Regarding breastfeeding, dexamethasone is thought to likely be safe. In regards to Meritor criteria, if a patient requires supplemental oxygen or mechanical ventilation, then dexamethasone would be initiated. Remdesivir may help to ease the course of disease in a non-pregnant patient with severe COVID-19. With a randomized trial in the New England Journal of Medicine showing remdesivir shortening time to recovery from a median of 15 to 10 days in adults hospitalized with COVID-19 with evidence of lower respiratory tract infection. Remdesivir is an antiviral drug. Its use appears to be safe in pregnancy and breastfeeding. Remdesivir was previously used in pregnancy during the Ebola epidemic in 2018. 6 pregnant women were treated without any adverse outcomes reported. Remdesivir has been associated with elevated AST and ALT, therefore these should be followed. Criteria for use at Meritor include an SpO2 less than 94% on room air, requiring supplemental oxygen, mechanical ventilation, or ECMO. Typically, this is similar criteria to when dexamethasone would be used. In non-pregnant patients, there's evidence that convalescent plasma may be helpful in critically ill patients. Reported use in pregnancy has been limited. Some case reports of these medications have been promising, including one from our own department. This patient presented at 26 weeks with acute respiratory distress syndrome secondary to COVID-19 infection and was treated with dexamethasone, remdesivir, convalescent plasma, and mechanical ventilation with cesarean delivery at 29 weeks for worsening maternal status. Looking into the future, on December 1st, SMFM released a statement regarding SARS-CoV-2 vaccination in pregnancy. This statement first highlights that only an effective vaccine will be the end to the pandemic, and that even though this is the case, pregnant women have remained an exclusion from vaccine trial participation. Despite this, the statement reviews the 3 vaccines that have been recently highlighted in the media. The Moderna and Pfizer vaccines are mRNA-based and use a vaccine expression from the nucleic acid construct. The AstraZeneca vaccine uses a viral vector, which is similar to what was used in the Ebola vaccine. Of note, the Ebola vaccine was used during pregnancy and has had an acceptable safety profile. Regarding the mRNA-based vaccines, SMF states that mRNA vaccines, which are likely to be the first vaccines available, do not contain a live virus, but rather induce humoral and cellular immune response through the use of viral mRNA. Healthcare professionals should also counsel their patients that the theoretical risks of fetal harm from mRNA vaccines is very low. The statement then goes on to say that although pregnant women are not explicitly targeted in this framework, pregnant and lactating women who are otherwise eligible should be offered the vaccine. SMFM recommends that healthcare workers who are considered prioritized for vaccination be offered the vaccine if pregnant. Since then, on December 11th, the FDA granted emergency use authorization to the Pfizer vaccine product. The next day, the ACIP recommended use of the vaccine, and the CDC accepted those recommendations, stating that the Pfizer vaccine can be administered to persons 16 years and older. On December 13th, ACOG released recommendations regarding pregnancy and lactation with the vaccine. And then on December 14th, vaccine shipments arrived at UW, and the first doses were administered at UW, the first one being to this worker. Now that we've finished the talk, I wanted to go back to our initial poll and see what everyone's comfort level is in caring for a pregnant patient with COVID-19. Again, the choices being very comfortable, somewhat uncomfortable, and very uncomfortable. Okay, it looks like everyone is somewhat comfortable, which is probably a good place to be. I'll move on to my references and then acknowledgments. So first, I'd like to thank the department for all of their support over the last 4 years in regards to my training. In terms of this talk, I want to specifically thank many people who were extremely helpful, particularly with the ever-changing guidelines. In OBGYN, Drs. Igor, Anthony, Sempene, and Bettigig, and Carla Griffin. In internal medicine, Drs. Lowry and Safdar. In pharmacy, Dr. Lauren Kolb. And the NICU, Dr. McAdams, the librarian, Robert Kohler. My family for their continued support, and my fiance, Michael Madigan, for his guidance. Thank you very much, and I am happy to take any questions.
Great. Thanks so much, Melissa. That was wonderful. That was really informative and a good kind of pulling together all of the available information that we have right now. I'll open it up to anyone with any questions.
This is Jay. I have a couple questions about anticoagulation.
Yeah.
So let me make sure I've got this right. If someone is COVID positive and they've delivered, then you consider 10 days of anticoagulation after?
So currently the guidelines are 10 days from the time of diagnosis. And regarding after delivery, it would also be taken into context with other comorbidities that they might have. So with pharmacy, they in general would recommend 10 days from diagnosis, but if the diagnosis were greater than 10 days, then it would be a discussion on an individualized basis, is my understanding.
So that would be including patients you're seeing in the clinic. If you see someone at 28 weeks that's positive, you should be considering this too?
Yeah, it's for people with severe or disease. So let me go back to that specific slide really quick. So if they have moderate to severe illness, then that's when you'd consider that anticoagulation treatment. And Dr. Igor, let me know if that's changed.
Yeah, so it's not for asymptomatic people. It's for people that are mostly hospitalized at any point in their pregnancy. So the person that you have in your clinic that is asymptomatic does not need anticoagulation.
Okay. And then my other question is, has there been any discussion or consideration about aspirin therapy in the clinic setting in patients who are asymptomatic or have mild disease?
So from what I've read, it's been talked about. My understanding right now is that it would still be just for the routine guidelines and not specifically indicated for COVID-19 patients, but there hasn't been definitive guidelines, at least that I've seen, from either ACOG or SMFM.
Okay, thank you. That was all my questions.
Thanks.
Well, people think about questions. Great job. You really summarized it well. And this is true as of 8:44 this morning.
Yeah, exactly.
So,
Yeah.
So where do we stand on the mild to moderate disease and the monoclonal antibodies?
That's a really good question. I think that that's currently being studied. I know on the Meritor website, they have some information on monoclonal antibodies. I haven't read a lot about it in pregnancy. I think it's really a new topic that is probably on an individualized basis at this point, but something that we should definitely continue to watch for.
Melissa, this is Anastasia. I'm just anticipating, thinking about the questions that come up from patients regarding vaccination in terms of when, if, let's say, you get the first vaccine, when should they be considered immune? When could they change their behavior or their family members' behavior or those kinds of things? Are there any pieces of guidance around vaccine and timing of expected immunity?
That's a really good question. My understanding at this point, and I do think that will have continued information forthcoming, but so the second dose would be 21 days after the first. And then my understanding is after 7 days after that, you would have like 95% chance of immunity. At this point, it's mainly protective against you. I don't think that we know exactly if you're not still able to transmit it to others. So those are going to be things that we should continue to look out for. Again, Dr. Igor, if you have any other more recent guidance, but that's my current understanding.
No, that's true. I think that the message, at least for now, is that we should consider to do everything that we've done up to now, even though people may be vaccinated or not, because we don't know. So basically wearing a mask, washing your hands, and doing this. So getting vaccinated doesn't mean that until we have community or herd immunity, we're still sort of where we are. So the idea for being immune is, as Melissa said, most people will develop within 1 to 2 weeks, but there's people that may take longer. There's people that may not respond, and we don't know, the recommendation. We know for a fact the recommendation is that you still wear your mask, even if you're vaccinated. We don't know if people are able to transmit it or not. We hope not, but so I will err on the side of being cautious to tell them, no, it's not like you can have a party with 30 people that have been vaccinated.
Mm-hmm. And Anastasia, there is a smart phrase. I know Dr. Anstey has one right now, but that is going to be available too for some OB providers. So I think as continued information comes out, hopefully that will be a helpful way for everyone to be on the same page.
That has been provided already. So it was sent, I sent that email through Carla Griffin's office to all providers, and that went out a couple of weeks ago. So.
And that smart phrase is available in both the Meritor and the UW-EPIC system.
Melissa, I'm sorry if I missed a great talk. I think that was wonderful today, but did you talk at all about recommendations for people who are admitted with COVID and then they go home still pregnant for follow-up? And I mention it because it's one of the most common questions we get, like, what do you do with those patients?
I didn't specifically talk about that. I mean, I think in terms of medications, I kind of talked about with continuing like the dexamethasone for 10 days or until discharge and the Lovenox. But I believe, again, things are ever changing, that you would want someone to at least have a follow-up, either phone or in person, depending in like 1 to 2 weeks is my understanding. And then in regards to antenatal testing, if that's also what you're referring to, I have a little bit of information here. And these are the guidelines currently at Meritor in terms of what you would want to do if somebody was hospitalized or had severe disease in regards to growth ultrasounds, antenatal testing, delivery, anticoagulation. So I think that might have been a little bit what you were getting at, Dr. Happy.
Perfect. I just think that's really important to disseminate so people kind of have guidance on that. So great.
Melissa, do we know if there's any immune response after the first dose of vaccine?
I think there might be a little bit. I don't know exactly the number, like 75 is coming up in my head, but I'm not sure. I think that the most evidence is from both of the vaccines. So if someone were to get it, I would really encourage them to get both doses.
I think 50% is what they quoted this morning. So
there appears to be significant flattening of the curve with one dose of that Pfizer vaccine, and just with one dose.
And again, I think more information will, of course, be forthcoming soon. So. Oh, thanks. Shannon just said 52%. So thanks.
Great. This is a great talk and a great discussion. Anyone with any additional questions? Dr. Anthony put the smart phrase title in the chat here. It's .COVID vaccine pregnancy for anyone who is interested in taking a look at that and using that. So that's very helpful. Thank you. We'll check on if that dot phrase needs to be shared or if you can request use of it.
Yeah, I'm not sure. I think you might need to request it or look into it.
Essentially what you can do is, if I haven't personally shared it with you, you can look under like smart tools and you can look at other users' smart phrases and you can share it with yourself there.
Yeah.
There's a way to kind of do that.
You can copy it to yourself, I think. Yeah.
Yeah.
Yeah. I go look at Anthony's.
Mm-hmm. Yeah. And I can, if you email me, I can also like send you screenshots on it.
If you copy it, I don't think it'll update it when you update it, but if you share it, then it will update to everyone. Is the one difference, I think, from my limited Epic understanding.
Exactly. Yeah.
Yeah.
All right, great. Anyone with any other comments or questions for Dr. Meyer this morning? Or Dr. Igor? All right.
What was the question? I'm on the phone. I'm on call.
Oh, no, we were just
no questions.
No questions.
Okay.
All right.
Sorry.
Thank you so much. This was a great talk, and thank you everyone for joining this morning. Have a great rest of your day.